Okay, this is a short one. Just how to wean your patient off mechanical ventilation. Probably this is something of interest for you because it's challenging to take these people off the ventilator. But again, whatever I said earlier, always ask yourself why my patient the ventilator. If you don't challenge yourself every day, maybe you can ask people with you what can we do here. Always have this question in your head. Otherwise, your patient will be in a ventilator for a longer time. معنا؟ تصور. فوتو كاميرا. Okay, so this is the what we call weaning or liberation. So before you wean someone from mechanical ventilation, you ask yourself, what question you ask yourself? Are they ready? Right. So you have someone who is on, okay, let's please. So if you have someone on propofol infusion, he's on analgesia, say morphine or fentanyl or whatever you have in your unit, or maybe even paralyzed, came in 3 days ago with a bad pneumonia. That's a real scenario. And now his FI2 is better. You think he's improving. His inflammatory markers are coming down. You're given the right antibiotic. Looks good, right? So the first step you do is wake him up. So the first one is wake him up. So you need to stop the sedation, right? So is my patient ready? So he's paralyzed, sedated, he's ready, but I don't know when I wake him up if he'll be ready or not. So step number one is readiness. And one of the readiness is stop the sedation. Why we stop the sedation? Because we want to see his neurology, first of all, and we have to see what's his lung dynamics when we take off the support or when we let him breathe in his own. So readiness, and we do objective evaluation. We don't only look at the awakening, if he's awake or not, but we look at different things which we'll go over now. And then if he is good here, he's ready, then we will give him what we call a weaning trial. And we will go over what's a weaning trial and how you can do a weaning trial. So there's something called daily interruption of sedation. Most of the big centers, they do that. Every day, you walk to your patient, you ask, or maybe you have a protocol in your unit saying, ask you to stop the sedation on that patient. He's on 5 of propofol, and again, 2 of fentanyl, for example. I'll stop it, and I ask my nurse to assist this patient. How is his neurology? How's his breathing? Does he need sedation? Do I need to go down the sedation? And definitely if you do this every day in your patient, you improve a lot of things. You improve the length of stay, you reduce the risk of pneumonia or ventilation-associated pneumonia because you extubated your patient earlier. You improve the outcome in general and you improve the mortality. It's well-documented, evidence-based practice. Every day, they're called daily awakening trial. Daily awakening trial. DAT, right? And there's a protocol for a few, again, if you Google it, you'll find a lot of talking about daily awakening trial. So this is the daily interruption of sedation. Now, what are the required criteria to wean someone off the ventilator? And this you should be able to help me or answer it. And I'll go, hold on. We'll go one by one because there's a lot of them. And you can start from here. Doctor, you think your patient is ready. What you should be looking at in your patient to say if he's ready or not to come off the ventilator. Tell me one.
Respiratory shell index.
Respiratory rate. Before you go to this fancy weaning.
Respiratory rate.
Okay, respiratory rate. What should be the rate?
في النورمال تحت 20
تحت 30. Okay, remember this number.
Off vasopressor.
Very good. So my patient is hemodynamically stable, or he's in a small dose of vasopressors, like in 0.01 of noradrenaline, or maximum 5 of dopamine, or something small, so I can take him off. 3.
The cause of
Perfect.
Yes.
So that would be the first question before I look at the RSBI or anything else. I intubated him for a pneumonia. Is the pneumonia getting better? Is the gas exchange getting better? If he's not getting better, I'm not going to extubate him, right? So the reason for the intubation has resolved completely or resolving. He's getting better, right? 4.
Duration. كم ليه المدة اللي كانت على duration؟
That's not important because you can extubate someone in 1 day and 4 days. The longer is the worse, the outcome, I agree with you. Like it's not. How about FiO2?
Yes.
What do you want your FiO2? خليه هو يجاوب. The FiO2, how much FiO2 you're allowed to extubate? Someone in 80%, can you extubate him?
No.
No. Right. So it should be on 40 or less. So if my FiO2 is 60%, I will not. And I did a blood gas and his PaO2 is 60, probably I cannot lower down the FiO2. So I'll walk away and I'll try again next day. So FiO2 should be less than 40%. Doctor, what else? There's a lot of things there. So my patient is awake. So he's awake. He said that already. Okay. Anything?
Proper respiratory effort.
Huh?
Proper respiratory
Very good. So he's awake and he can trigger the vent. You don't want to wake up someone who's been sedated for 3 days and he's just zombie laying in the bed there, or having some brain issue, or he's in a coma, right? So someone who can trigger the vent.
Metabolic.
That's okay. Anything else? It's okay. If you don't know, you don't know. No? Victoria? Anything else? Here. So he's not severely acidotic, right? I will never extubate someone with a pH less than 7.1. 7.1. You can do 2 if you want to play it safe. Victoria? Anything else? Victoria? No. Over there. Victoria, anything else? And I'll tell you a strategy how to do it, but I just want to wake up. So he had a good cough, he can protect his airways. So someone you suction him, right? Or you tackle his trachea and he's not coughing, so you take the tube out and he will drown in his secretion. So don't extubate these people. Very good.
NABG, PF2 should be more than 6.
So we have a good gas exchange, right? pH is good, PaO2 is good there, right? His CO2, I intubated someone with a COPD patient and CO2 to back to the baseline.
After the PO2 and FiO2 ratio.
Yes, you can use that
More
too.
than 300. So.
More than 150, yes. Anything else? Mujahid, you want to add anything? Okay. So you can do it in a systemic way. You have a patient laying in a bed. I'll tell you what I do. Laying in a bed, you have a monitor there, you have a breathing machine here, and you have a patient. You have to look at the patient. He's good. Look at the monitor. Numbers looks good. Then look at the breathing machine. Good. Give him a weaning trial. So what you look at the patient. Patient is awake. He can protect his airways. And if I call him, he responds. I'll tell him, okay, show me your thumb. Move your fingers, right? Lift up your head.
Being command.
He's a paying command. Simple commands, right? Not you don't have to write a story for you. Just a simple command. Show me your right hand. When you cleaning a hash. Now he's awake. So this is a way, objective way of assessing his neurology. He have a cough, and the best one who will tell you if he has a cough or not will be the nurse. So he's coughing. He can
Suction.
yeah, or you suction him if you say I don't know or I'm fikra, but you can suction him and see if you have a good cough, right? So he's awake, he can protect his airways, right? Hemodynamically he's stable, it's not like someone who's in 3 pressors or 2 pressors, right? Then you go look at the monitor. He's not hypotensive, he's not hypertensive, he's not tachycardic, he's not tachypnic, and his saturation is good. Just by glance, looking at the monitor, you'll figure all of this. Less than a second, right? Then look at the ventilator. How much FiO2 I'm giving to him? Less than 40. His PEEP is less than 8 or 5. Let's play it safe. 5. PEEP of 5. It's not a PEEP of 12, right? And he's generating a good tidal volume. His tidal volume is good there, right? And there's other parameters you can look at, but these are the main ones. This is, you do all of this once you stop the sedation and you put them on pressure support. You don't do while they are in rate. Right, so awake and alert, or easily arousable, cause of the respiratory failure improved or improving, and if you have a ratio more than 150, saturation not more than 90, you can do any one of them. But the FiO2 should be less than 40 or 40 with a saturation of more than 90. If you want to do the BF ratio, you can do that too. PEEP is less than 5. Good acid-base balance. Hemodynamically stable, as we said. Able to trigger the ventilator. You can look at these things in specific situations. So if you don't want to extubate someone with a hemoglobin of 5, right? It's better to transfuse them before you do that. So hemoglobin, the cutoff of hemoglobin in the ICU is 7. If you transfuse someone, you make it 9. Do you help them?
Yes.
Do you improve the outcome? No. You don't improve the outcome, you didn't help them. You just blood transfusion. The rule of transfusion in ICU is 7, unless 2 conditions. You have someone
أصحابك وصلت التسعة تمام.
bleeding, actively bleeding. I don't care about the number. I'll give them a lot of blood there. Or someone they claim if he's on acute cardiac condition, so you have to support him. But otherwise, the cutoff is 7. It's not should not be febrile or afebrile. Don't worry about this gradient for now. So if you have someone, you intubated someone with myasthenic crisis. Okay, so this is what you should be looking at. Any neuromuscular problem, you have to look at maximum inspiratory pressure or maximum inspiratory flow. You know how to do it? So there's a small machine and you ask the patient to suck in. Okay, and you look at the number. It's always negative, and the number should be less than minus 20. If it's minus 10, that means they are not able to generate enough pressure to breathe in their own. So if the magic number is minus 20, or some people say minus 30. Anything higher, lower than minus 20 is good.
So different machine هذا القيس وش يعني؟
Now?
هذا different machine القيس يعني.
Yeah, it's like the spirometer. Like the spirometer. Something to do it as well.
Ask a patient.
Two.
In here.
Take a big breath, suck it in, right? And it's better to do it best of 3. Do it 3 times, because sometimes it's difficult for the patient to understand you. Then it can be a little bit sedated, drowsy with the medication. Just say, suck it in. You can do it through the machine. You can do it a separate machine. I'm sorry. You can do it a separate machine if you are having someone who's not intubated. My fault. But through the machine, you can do some ventilators that allow you to do it.
كمل الرقم.
Minus 20 or less. Minus 20, minus 30, minus 40. Vital capacity. That's important as well in people. You intubate for neuromuscular problem. Again, myasthenic crisis, Guillain-Barré syndrome, something to do with the muscle. That is why I intubated them. So vital capacity. What's vital capacity?
Inspiration. Maximum inspiration, maximum expiration.
Anything other than the residual
Residual
volume. Okay. What it should be before you extubate your patient, and what it should be when you intubate your patient. I have a patient walk through to the unit and you have a myasthenic crisis, right? Weak cough, secretions there, right? Saturation in the 90s. When do you say I want to intubate this patient? There's 2 things to look at. The negative inspiratory flow or pressure, the one you said that there, and the vital capacity. I don't care about the blood gas, I don't care about the CO2 retention, I don't care about anything. Any of these numbers, if the vital capacity less than a liter, that means this guy needs to be intubated, this patient needs to. If the negative inspiratory flow or pressure more than minus 20, means minus 10 or minus 5 or whatever, they need to be intubated. Reverse it now. If the vital capacity less than a liter, I will not extubate them. It should be a liter or more. or if you want to do it per kg, it's 15 cc per kg, 10 to 15 cc per kg. Clear?
في جهاز
The
مش هتشوف فايدة
ventilator
بس.
will do that for you. Total minute ventilation, these are soft indications. You don't want to extubate someone with the minute ventilation of 12. He's having severe sepsis, hyperdynamic circulation, breathing fast. You don't want to do that, right? So minute ventilation, frequency less than 30, tidal volume more than 300. Remember, all these criteria are based on no randomized trial, no good evidence there, apart from the one we will mention now, the RSPI. They are based on agreement. قاعدوا ناس مع بعض كده يقولوا level 4 of evidence. وقالوا okay, let's do a Weaning criteria, and we discuss it and we agree about it and it's there, but it's never been studied in details in a randomized studies. Consensus means agreement between people كده, well, observational studies, but no randomized studies. 30% is probably a little bit high, but if you extubate 100, you look at everything and everything looks perfect, and you say my patient needs to be extubated. If you do this in 100 patients, how many of them
30
you have to come back and re-intubate?
رينتبه
Re-intubate.
70 ولا
20
So if you re-intubate 15, you're good. That means you're doing a good practice. You're a very good physician.
والا كل شو بدك طول في
This is bad. So if you extubate in 5, if you re-intubate 5, your rate is low, 5%. That means you're keeping your patient a long time on the ventilator. And if your rate is, you end up re-intubating 25%, that means you're extubating your patient too soon, right? So the benchmark everywhere في العالم يعني يقول لك benchmark of re-intubation in any ICU is 15%, 10 to 15%. And this is one of the ways to look how good you are, how good is your ICU, right? In the JCI اللي حكيت عليها أمس مثلا, they look what's your re-intubation rate? Say at 20%. Say, oh, that's a bad mark. What's your line infection? What's your UTI, catheter related? So this is the thing they assess. This is one of them they look at when they assess you. But keep this number in your head. So if everyone you extubate flies, that means probably you need to be more aggressive in extubating your patient.
15%
10 to 15%, remember. So this is different indices they came up with. CROB, CORE, IWI, IE. You don't have to remember these. If you remember this one, it's easy to do. It's in your ventilator there, and you can check it every day. So how you do it? It's called Rapid Shallow Breathing Index, or RSPI, and basically it's the frequency divided by the exhale tidal volume. Exhale tidal volume, VE. So how you do it? I'm gonna skip this one because we've covered it already. So how you do it's a Spanish. Well, you have, I think some slides are missing here. Okay, so the rapid shallow breathing index. I'll go back to the other slides. I don't know why it's acting like this. So it's good evidence. There's a lot of studies there. It's very easy. Everyone to do it. Just basically you look at the how often my patient is breathing. You divide it by the tidal volume, and you look at the number. If the number is less than 105, it's good to extubate. You have a positive predictive value of 90%. This is very good, right? If it's more than 105, probably I'll just rest my patient and try again tomorrow, and of course I have to find out why he's failing. So I think we have the slides on how you measure pain. So first thing, you put your patient on pressure support. You make You ticked all the boxes for different. He's awake, he's alert, he protects his airways, blah blah blah, right? Then you put him in a pressure support ventilation, 10/5, and you wait for 2 to 3 minutes. Don't do it immediately. And you, after 2 to 3 minutes, you look at their respiratory rate, how much they're breathing, and you look at how much tidal volume they're generating. If they're breathing, say 20 times, his rate is 20 times, and his exhale tidal volume is 400 cc. What would be his RSPI? Something. We said we divide the frequency by the tidal volume. What would be?
قسمها على الأرض مش عارف
Okay, what do you tell me? You divide 20 by
كم التايدل فوليوم كم؟
400.
20 على 400 كم تطلع؟
Now this is what I want to say. So this is not 400. It's a fraction of 1. 0.4.
تحويل.
0.4, yes. If it's 300, it's 0.3. If it's 500, it's 0.5, right? So 20 by 0.4, what would be the number? More than 100, right? 100 and something. So this is the way you do it. It takes you like a few seconds to do it.
موجود على المتكال تدخلها طول.
Oh, you can do that, but it's always good to... So we went through two things. The pressure support, we went over it. It's very easy. Pressure support of 10, PEEP of 5. Leave them there 2 3 minutes. Look at the RSPI. And how long do you keep them in a pressure support before you extubate them? Minimum, half an hour. Maximum, 2 hours. Not like this. If you do it like this, what will
إلى ما
happen?
شاء الله.
What will happen? If you leave your patient in pressure support 10/5 and you come back 4 hours, what will happen to your patient? He will be tired, right? Because he's breathing through a small tiny tube and you leave him alone. You beat the kidney and you say, my patient
الصبح
failed.
لليل.
Yeah, I know some people do that, but it's wrong. So maximum 2 hours. In 2 hours you have to make a decision. I will extubate him or I'm not going to extubate him. If you don't want to extubate him, put him back on a full support. Right? Because after 2 hours they get tired and they fail, and this is your mistake. This is not their mistake. The other way of doing it is what they call TPs. We don't do TPs anymore now. But it's there. It means you do it to which kind of patient?
اللي هي بعد سبونتينيوس حطوا اكتيفيس.
احنا اللي يصير
خلينا نقول لك وقت يقول اللي يصير بس we don't get distracted. Okay, so stay with me for another 5 minutes. So the TPs, you switch everything off. Still intubated, still connected to the ventilator, but there is another hole in the side where the patient can breathe in and out. You leave them there for same story, half an hour to 2 hours. They're good, you extubate them. Nowadays, the only time you do this TPs is when you have someone with bad heart, congestive heart failure. Why you do that? Because you want to get rid of the PEEP, because the PEEP help them to open their lungs, help their pulmonary edema. So it's kind of help. But once you take it off, that means they have no PEEP, and you give them. If they fly after 2 hours, that means 100% they will do well after extubation. Right? So you do either one of them. Both of them are the same. The outcome is the same. Study-wise, they're the same. Evidence-wise, they're the same. The only difference with the pressure support compared with the TPs, pressure support, if the patient stops breathing, the machine will alarm. It will call you. It will call the nurse. But with the TPs, everything is off. If he stops breathing and he dies, you will not know him. So this is why the people shy away from the TPs, one of the reasons. Now tell me how you extubate. Let me just do quick what we did this already. So this is my suggested approach, or this is what we do. So patient is good, awake, alert. You tick all the boxes before. Put him in a spontaneous breathing trial, 10/5. Make sure his FiO2 is 40%. He's hemodynamically stable, responding to you, have a good cough and he can protect his airways. The RSPI is less than 105. ABG have a good gas exchange and his CO2 within range. 20 after maximum, you can do it after 31 minutes if you want. Young guy who have a bad asthma, he's opening up, he have no more wheeze, X-ray looks good. Why you have to wait for 2 hours to extubate him? But this comes by experience, right? You don't jump and do it today. But you see it 1, 2, 3, 10 times, then you say, hey, this he will fly, he will do good.
حتى الانتبيشن نوت لو مثلا هو كان difficult intubation وكذا والى اخره مرات ما نستعجلش فيه لين.
Yeah, this is the clinical judgment, and this is what I'm going to say here. So all of the above are good. You can extubate your patient, but always, weaning people and extubating people, use your common sense and clinical judgment. The more you see, the better you are. Sometimes you don't care about all of this. He's awake, he can trigger the breath, I'll extubate him. He doesn't give you time, especially a young patient who, as soon as you stop the sedation, he will start fighting. He will start fighting, and his rate will go up. His respiratory rate, heart rate goes up, blood pressure goes up. If you follow this strict criteria, you'll never extubate him, right? Especially you don't have this fancy medication, the one we mentioned yesterday. But just take them off. Sometimes you have to do that, but again, you have to do it with experience or supervision. So why people fear extubation? He did all of the above and he fits it, but once you take the tube, the nurse will call you back, he's saturating, he's dropping, and you need to reintubate him. What makes, what criteria, or what's the reason for failed extubation? What happens if you, someone... It's weak. Muscle issues, right?
Yes.
He's wasting, he has a split
No, it's ventilator dependent.
Ventilator dependent means muscle issue.
Yes.
Okay. One is muscle issue for prolonged intubation. What else? You don't do a good job in assessing him, right? His pneumonia is still bad. You extubated him before you get your MRSA culture. Once you extubated him, they say, hey, he has MRSA in his lungs, and it's a disease is bad. So take your time. Okay. What else? Bad heart, right? You stop it, the heart is just, you are supporting him with 8 of PEEP, you take off that PEEP and his heart fails again, right? Borderline, his EF is 30% or 20%. Probably if you work here, you will see it a lot. So bad heart is pulmonary edema. What else? So, this is this criteria of extubation, and we said that already. He doesn't have a cough, right? We'll just mention a few words about this. Anyone heard about this cough leak test?
Yes.
Okay, what's cough leak test?
فيش الوقت.
No, I said who heard about it. Nowadays, some units, they have one of their criteria. If your cough leak test is negative, they don't extubate you. So a cuff leak means you deflate the balloon of the ET tube and you look how much air is wasted. So remember, the machine will measure anything goes through the tube, right? I give 500, if 500 comes out, go through the machine and the machine will calculate and say 500 came out. Everyone is happy. If you inflate the cuff, deflate the cuff, the air will be leaking outside and the machine will not read it for you, okay? So I'm given 500, I deflate the cuff, and the machine is reading 300. You're good. If the machine is not reading anything, if the machine reading the same 500, that means there's no, this is bad. If the same number you give comes out with the cuff deflated, that means there's no leak. Everything goes through the machine. What does it tell you? There is airways are swollen, they're angry. Yes, there's edema. And which patient I intubated someone, for example, with angioedema, right? So this is a way of doing it. Someone with a trauma to the neck, something you should keep in mind. So you should do this cuff leak test. In this kind of particular patient, you should not do it in everyone. Or you do it in someone who has been intubated for
long time. طيب نسأل بس قصدي deflating التيوب بالبلن يعني must indicate ان الباثولوجي في trachea مش something down.
ما فهمتش.
يعني انت قلت لما احنا ندير ديفليشن المفروض كل ما لو دخلت البول 500 طيب طلع لي 500 معناها this is very bad معناها ما فيش ليش صح ولا؟
Yes. Means
كويس.
the airway are swollen.
كويس ايه بس معناها الباثولوجي must be inside the trachea.
It's a consequence of you. And they intubated him for, if not for pulmonary edema, for angioedema, you intubated him for pneumonia.
Okay.
But he's on the vent for 2 weeks or
Yes,
10
very
days.
long time, yes.
And you cuff pressure.
Yes.
What should be the cuff pressure?
20
Not so much high.
20 not more than 20
20, not too much high. I need a better answer because this is one of the common
Yes, I think
mistakes.
10 cc.
ما يقيسوش
You don't measure.
ما يقيسوش فيه.
You don't measure, but you're supposed to measure.
10 to 50 I think.
10 to 50. So the cuff pressure should be the pressure what prevents leak.
Yes.
So you go slowly with your syringe till you hear no leak and you see no leak in your ventilator. This is your cuff pressure. Should not be higher than 30. If it's higher than 30 will cause
Tracheal ischemia.
ischemia and necrosis and swelling.
Herniation. Herniation.
And swelling. And this is one of the reasons if you have someone in mechanical ventilation for a long time
Yes.
and people just squeezing air in that cuff is inflated, you don't pay attention because you're busy with the pneumonia and with his hemodynamics and whatever, and you will end up with problems up here. So this is why you have someone in a long time on the ventilation or intubated for a long time, you have to do the cuff pressure before you extubate them. Because you don't want to take the tube out with the swollen airways and the nurse will come to you and say, hey, you have an
Hypoxia.
stridor. You cannot breathe. Every time you take inspiratory breath, you hear that squeezing sound. All of you hear stridor before, right?
Yes.
Right?
yes, right.
Then you have to go back
By
and...
the way, stridor is very difficult to intubate.
Yeah, can be. You have to use a smaller tube, you have to use a local epinephrine nebulizer, and it can be challenging. So we do the cuff leak. We have a good leak there. The good leak means more than 160 cc if you want to remember this number. Or some people say more than 15% of the inhaled tidal volume. That means they have a good leak and you can extubate them.
15 ده على الكف ليك.
Cuff leak 160 cc. So if you give them 500 tidal volume, the machine should record for you 340. If it's more than 340, that means he doesn't have enough cuff leak. One more thing about the cuff leak, if you want to remember, it has a high negative predictive value. What does it mean? You use that D-dimer here to diagnose PE, right?
Yes.
If you have a PE, I'll do the D-dimer. If D-dimer is positive, means
Means
We have
don't
to do
be
other.
non-specific.
it could be anything, right?
Non-specific, yes.
If the D-dimer is negative,
Most likely.
99% there is no PE, right? You apply same principle for the cuff leak. If the cuff leak is not there, you have a good cuff leak, 100% there is no
Yes.
swelling there, I'm happy. If the cuff leak is there, if the cuff leak is positive, means exhaling less than 160, could be there, could be not. Right? It's just helping to, something helps you. I'm confusing you. Weaning failure, we said that, overload, cardiac dysfunction, muscle weakness, patient become delirious and anxious. You see it more in males, you see it more in young patients, you see it more in asthmatics, metabolic disturbances. You don't extubate someone who is about to have a dialysis session, for example. His urea is whatever, creatinine is high, he's severely acid dialyzed and then extubate him, right? So you extubated someone, fills the criteria. No, you didn't extubate him yet. You put him in pressure support. You come up back 2 hours later. He become tachypnic, hypoxic. You said, "Oh, I'm not going to extubate this guy. I'll just leave it." How long do you leave it? When do you try again?
Second one.
Thank you. Don't try 2, 3, 4 times a day. Once per 24 hours. This is based on studies again. We do it today. My patient failed this morning. I'll try again tomorrow. Between today and tomorrow, you will put him on full support. Don't leave him in a pressure support. Put him in a full support. He was in volume controlled rate of 20, put him back where he was before, when he's stable, and try again 2 more. Okay, so one trial of weaning per 24 hours. You have a COPD patient. This is the last slide. I know you're tired, and I'm tired too. You have a COPD patient. You extubated by he became tachypnic. Saturation started a little bit dropping, and CO2 crept from 50 to 55. If you remember what we said about non-invasive yesterday, put them in non-invasive. They will fly. They will do good. You will not need to intubate them. Not all of them, but a good chunk of them. So try non-invasive and COPD patient you extubate. There's 2 schools here. One, you take the tube out, you put the non-invasive immediately. Don't wait. And this is the best approach. If you think the clinical judgment tells you, oh, probably he will fail because he's been ventilated for 10 days, long time. We've been struggling with his CO2. We hardly just put him under control. We'll come back in an invasive straight away. Or if you think he will do good, you wait. If he doesn't do good, put him in an invasive, and you save a lot of them. You save them the intubation. Yeah. So use your non-invasive. And if you see here, it's 25 trials to prove this. Any questions about me?
عندي سؤالين.
تفضل.
هل في مثلا بروتوكول معين لموضوع البوست اكسبيشن ولا حتى بالاكسبيشن الكورتيزون انك تعطيه نيبولايزر تعطيه هاي في
Cortisone.
ديكس
What
على
cortisone?
اساس الاير واي وديما وجهده.
So if your patient end up with a stridor after you extubate, is that what you're saying?
لا هيك بروتوكول حول التيوب حط نيبولايزر.
more than 2 days.
This is Egyptian medicine.
Yes.
لا لما يبدا more than 2 days
doesn't
ما يضرش.
right antibiotics.
ما يضرش يا دكتور، ما يضرش.
ها؟
مش هيضر.
بالظبط مش هيضر يعني. هينفع ممكن ما يضرش. No, we don't do that. There's no protocol of steroids unless you have stridor, airway edema, and even steroids in airway edema. If you don't search for it, there's no evidence for that. You know the mechanism of action of steroids is it reduces the swelling, right? So we assume, but there is no randomized study saying steroids helps people with angioedema. But we do it because we have much to do, right? We give bicarb for lactic acidosis, right? Does it help? No. Does not help. But we do it before, what was supposed to do the lactic acidosis? The pH is 7.9, 6.9. I give my carb. It will go up and it'll crash again. You have to treat the reason for the acidosis. Where is lactate coming from? Fix that problem, you fix your acidosis. Giving bicarb will help you a little bit, and you have someone with hyperkalemia, potassium 6.9. What do we do? What's medical management?
انسولين دكستروز وبنتلين.
What insulin will do for you?
شيفتنج كذا.
Shift it, right. Up 2 hours later,
مرات
come out again. You did nothing. 3D, reason for the... I'm not saying don't do it.
Yes.
Do it to buy time, but does not solve your problem. I'm just giving you more examples.
دايوريسيس هيمودايسيس هي
That hemodialysis or hemodialysis. That's the only option. Okay, so back to your no, we don't. But you can have
على
your
السؤال
تفضل.
نفس النقطة. أنا لو إن خليناه في سلايد واحد
ها؟
مريض حطيناه عليه في سلايد بدأ ياخذ في سلايد نعطه ستيرويد حطيها
خطيه معروف.
So if you give someone steroids, how soon the steroids will kick in? Will work?
تاخذ وقت
هو
Work how much?
6 ساعات.
8 hours, 8 to 12 hours. First, how the steroids works? How? Mechanism. Why it takes 8 hours?
انترسيلر
Works through protein synthesis, right? Works through the
نيكلز.
RNA, DNA. So it works. That's why it takes forever. It's not cell
حتى في الانافيلاكس هذا ليش ما فيش هذاك الرول.
You give it just to prevent it, right? But it's not going to give you
هي
immediate
الفكرة
effect.
لما نوجدها أن تعطيها قبل 24 hours.
معناها كل يوم تعطي.
Actually,
مثلا خلاص أنت قررت ممكن تسوي في الاكسبريشن.
that's a different story. This is a personal experience. أنت صارت لك من قبل يمكن حسيت إن البيشنت هذا will have a stridor. والله he was intubated extubated before عندك في اليونت وعارف المريض هذا جايك مرتين ثلاثة وحصلت نفس المشكلة تقول I'm giving steroids just to prevent it but it's not everything you don't do it in everyone you don't do it in everyone it's not practice.
كويس. سؤال ثاني.
تفضل.
السيديشن بروتوكول. انا سمعتك قلت بروبوفول، يعني تعطي بروبوفول حتى الهيمودايناميك انستيبل.
يس يدوز.
لان احنا اللي ماشي معانا رادورمي كونفنتن، هذا
ماشي معكم
ميدازولام وفنتانيل.
So the rule for okay, we're talking about something else. So the rule for propofol in ICU, it's 48 hours. You should not. I would not say you should not, but try to. I'll give you a real scenario. I have a patient that came in
دكتورة فاطمة.
with a stroke, for example. That patient you have, and he's half awake. He's just fighting, and I intubated him for airway, but he's fighting, right? Oh no, not stroke. Subarachnoid hemorrhage. Someone came in with subarachnoid hemorrhage, right? GCS was 9. He's going to the OR tomorrow, or going for intervention, whatever. So I intubated him for airway protection, but he's awake and he's fighting. So I want to shut him up. Can give him propofol. These are the indications. For neurology, for someone you need to assess every day. Why we do propofol?
Weaning انتهت.
Because once you stop it, you have a very short half-life. You stop it, your patient awake, you can assist them, and you're not happy, you knock them off, you put them in the propofol again. You watch for a couple of things when you have someone on propofol.
Maybe.
The dose should not be high, right? Should not exceed 50 mics per kg. You always start at 5. This is a very small dose, and you build up the dose. The minimum dose is to keep your patient comfortable. And comfortable, this is a different story. The other thing, you watch for how long you give that propofol. Because if you give it, the longer you give it, the more risk of infusion syndrome. Propofol infusion syndrome is a killer. It's ICU killer. The mortality rate is 80%. So if someone gets a propofol infusion syndrome, you're in trouble. And the trouble, I did it because I did not watch how much. If you give higher doses, you increase the risk. If you give a longer time, you increase the risk. So propofol used with caution, right? But if I'm giving someone fentanyl max dose, I'm giving midazolam huge dose, I'm giving ketamine big dose, I'm giving things, and the patient is still fighting, I'll give a propofol, and I just have to watch it. You can give it longer than this. So if your patient needs sedation more than 48 hours, use benzodiazepines. If your patient is, he's just overdosed and protecting his airway, and probably by tomorrow he'll wake up, I'll extubate him, give propofol, right? Neurology patient, give propofol, because you need to assess neurology every day. ARDS, severe ARDS, he will be with me in the unit for the next 7 days. Why I'm giving propofol here, right? For the hemodynamics, again, the evidence is not very good there, but if you have your patient who have a bad heart, you have a patient who's been sick for 10 days, dehydrated, not eating, neglected, living by himself, right? He will be in the dry side again, and you give him propofol. Of course, he will crash his blood pressure. Even these people, when you intubate, they will crash their blood pressure because you create positive pressure in their chest and you affect the whatever we discussed yesterday. So it's a judgment call. But the rules, 48 hours, watch the dose, watch the duration. If you do it for 5-6 days, you also have to think about the lipids, triglycerides, because triglycerides will shoot up and your patient end up with pancreatitis. So you have to watch it. If the triglycerides start creeping up, you have to think about something else. Benzodiazepines, it's a good option, but the problem with the benzodiazepines is delirium, right? So 80% of your patient will have a delirium. Whatever you do with benzodiazepines. And delirium is a nightmare. You have someone who start acting in the ICU, you don't know what to do, because there's no treatment for delirium, right? Especially in our setup here. There's no medication, there's no evidence-based medication helps you with delirium. We give, there's no evidence, go and search it, there's no evidence for haloperidol. It just makes you shake. Your patient will sleep for a couple of hours, but he wakes up delirious.
Treatment for staff, not for doctor.
Yes, it's treatment for us, not for him. People use the drug I mentioned yesterday, the dexmedetomidine, the Presidex. Again, there's no evidence at all for any medication to use it. People use antipsychotic as well. There's no people use clonidine. They're all just stuff to keep patient, but does not treat the primary problem. The pathology in the brain, we don't treat it.
فلومازينين يعني ولا شيء ما يديرش.
Flumazenil, this is what's flumazenil?
حش الدليل ما ادري مثلا.
No, actually will make it worse.
Antidote.
No, there's no treatment for delirium. The treatment
Prevention.
is prevention and non-pharmacological. You have a family sitting next to the patient, you talk to them, you open the window, daylight, night light, TV, مش عارف ايش، تحكي معاه، تطلع في الكرسي لو تقدر daylight، يعني non-pharmacological, but medications to help to kill the delirium, no, there's nothing. So, what was the answer?
sedation protocol.
I talked too much question. I talked too much. What was the other question?
sedation protocol شنو الافضل sedation نستخدم؟ هذا اللي حكينا عنه.
sedation تو كبير.
ممكن لو دخلت عندك شريحه حتى هستني او شيء
كيف؟
كاميرجنسي
ما عندك شيء history, use whatever you have. Use whatever you have.
كيتامين انفيوجن استخدموا شيء.
Ketamine is
secretion.
it's good if you have a bronchial asthma, for example. People claim it's not good for the brain as well because it reflects tachycardia and causes raised your ICP for someone. If you incubate someone with a neural issue, with the high ICP, his CT scan brain looks swollen, or you have a monitor there until your ICP is 25. Don't do that. But again, use whatever you have in your unit. There are different schools, different people. Your experience with benzos is good. You've used benzos, like modern ventilation. Use benzos, but just have to keep these things in mind. If you have someone with a bad liver, bad kidneys, and you give them benzodiazepines, and you say next day, oh, they're ready to be, and you try to, they're zombie, they're not waking up. They will be asleep for 2 days. Right? And the family will be in your head, why he's not waking up? And you end up doing scans and doing this and doing that. Because you give him benzodiazepines. Because his benzodiazepines big dose for a week. So maybe someone with a bad liver and bad kidney, I'll pick something else. Maybe I'll pick propofol. Maybe I'll pick ketamine. Maybe I'll pick something, morphine, something. So this is whatever available for you. And if you have everything there, then use your clinical judgment. Okay, guys. Great.
Course.